we measure. We can measure so endless amount of data, but we cannot manage it. It's going to be done through the big data process. The very famous Harvard professor Christensen, he put the concept of disruptive innovation. Disruptive innovation is really something, not the improvement or development in the technique, it's something completely different. This is a classical example that he used to describe his concept in disruptive innovation. A long time ago, we used to have floppy disks, then hard disks, then flashes. Definitely hard disk, we have increase in capacity, etc. This is development. But going from hard disk to USB or flash, it was disruptive innovation. Going from USB flash to clouds, this is disruptive innovation. So disruptive innovation, it is not improvement or development in a product or service. It's completely different way in providing the product or the service. So we consider big data as really, and using clouds in big data is a kind of disruptive innovation in healthcare. Definitely big data used in all different specialties, but I am going to focus on healthcare. Definitely مش هبيع المية في حر السقايين. It's very difficult to talk about cancer في مستشفى 57 357 لكن actually despite considerable progress in prevention and treatment, cancer remains the second leading cause of death in USA and in many other countries in the world. In some statistics, actually, 75% of the patient receiving cancer treatment is ineffective. Going from the big C, cancer, to the big D, data. In the dictionary, big means, I'm sorry, big means ample, huge, large, sizable, jumbo, massive. Data, yes, okay, thank you. أكون شاكر. Data is a plural of datum, so this is big data. And usually the people in IT defining data as unprocessed information. We have three challenges in dealing with big data. And this is why such name is a kind of misleading name. We are not only talking about big data, but we are talking about the volume, big data, but also the variety. We have different formatting in collecting data. For example, each hospital, it has its formats in collecting data. Sometimes each department. Okay, Ministry of Health hospitals different from NGOs. NGOs may be completely different from private sectors, etc. Such system is dealing with different formatting and can manage having data with different formatting, different structure in data collection. And finally, velocity. Such sophisticated system in data analysis can manage data while we are giving different continuous change in the data. So if we are going to make changes in the data, the computer or the system is going to deal with it. So actually we have not only volume, but we have variety in formatting and we have velocity. So we don't have a statistical static system, we have dynamic system for dealing with data. When we talk about units, for example, for weights, we are talking about something like milligram, gram, kilogram. When talking about time, we can go from nanoseconds to centuries. When we talk about distance, we can talk from centimeter to kilometers or more. For data, we use a very basic unit. It's called byte. and byte is 8 bits. The byte is a kind of a single character, is almost 1 byte. When we talk about 1000 bytes, we are talking about kilobytes. Kilobytes, for example, a low resolution photograph is usually something around 100 kilobyte. So we are going to use some terms to know that when talking about big data, we have different terminology, which is different from the traditional units. Then, if we are going to have 1 and add 6 zeros, okay, bytes, we are talking about megabyte. Megabyte, something like CD-ROM is usually around 500 megabytes. Then we have gigabytes, which is 1000 megabytes. That is going to have 1, then 9 zeros after that. So such a floor of books can be stored in 50 gigabytes. Not only that, but we have terabytes. Terabytes, this is our age now. We are talking in dealing with data by terabytes. Terabytes is actually a kind of, terabytes, something like 10 terabytes, the printed collection of the US Library of Congress. أكبر مكتبة في العالم هي مكتبة الكونغرس. كل البيانات والكتب اللي فيها ممكن تتحط على 10 تيرابايتس. ما تنزعجوش قوي من الأسماء، مش مهم نحفظ الأسماء، لكن نبتدي ندرك إن حجم التقدم اللي حادث في تكنولوجيا البيانات unbelievable، سريع جدا. وأنا بشجعكم جدا إن أنتوا تضيفوا إلى التخصصات بتاعكم تخصص تحليل البيانات. تحليل البيانات في النيرسينج طبيعته والجماعات والكولكشنز اللي بنجمعها مختلفة إلى حد كبير عن اهتمامات الأطباء. الجزء الخاص مثلا بالكواليتي وصحة المريض والمزاج العام بتاعه والساتسفاكشن بتاع الأسر بتاعته، ده يمكن مش مين كونسيرن للأطباء، لكن بالتأكيد هو حاجة مهمة جدا للتمريض. فبالتالي أنا متصور إن حقيقي ممكن تبتدوا تقودوا مصر والمنطقة العربية في مجال البيج داتا، في مجال التمريض. ده مجال بكر محدش يشتغل فيه. الداتا عندنا هيوج، ضخمة جدا جدا جدا. السيستم ده قادر على ان هو يتعامل حتى لو كانت النماذج المستخدمة في المراكز الريفية مختلفة عن المدينة، مختلفة عن دار الفؤاد، مختلفة عن 57. السيستم ده قادر على ان هو يتعامل معاها. يمكن انا مش عايز اطيل على حضراتكم في حاجات تكنيكال، لكن عايز اقول لكم قصة حقيقية حصلت في الستيتس. في سنة 2009، يعني مش بعيد قوي، من حوالي مثلا 4 سنين وشوية، ظهر نوع من الفيروس للفلو. كان تركيبة كده مشتركة بين انفلونزا الخنازير وانفلونزا الطيور، وسموا النوع ده H1N1. ايه المشكلة مع النوع ده؟ النوع ده خلال اسابيع اكبر هيئة في امريكا اللي هي الCDC بتجمع المعلومات، السنتر فور ديزيز كنترول، عايزة تجمع بيانات عنه، ما عندهاش فاكسين للفيروس ده. ابتدوا يقلقوا جدا ان حصل وباء اسمه الانفلونزا الاسبانية في 1918، وخافوا ان هو يخشوا في نفس المجال. اللي حصل نموذج جيد جدا ازاي ممكن نستخدم البيج داتا او البيانات الضخمة. مفيش فاكسين، علشان يحطوا استراتيجي وهم ما عندهمش فاكسين، قالوا الاستراتيجيه بتاعنا ان احنا نبطئ انتشار الفيروس. يعني كل هدفنا ان ما ينتشرش بسرعه قوي لغايه لما نشوف موضوع الفاكسين. طيب السي دي سي في البروسيس بتاعته هيحصل ايه؟ هيحصل المعلومات بتجيلهم من خلال الاطباء. طب عشان تجيله المعلومات من خلال الاطباء بنحتاج لايه؟ اتاخد من اسبوع لاسبوعين، عقبال لما عيان يسخن وبعدين يشك وبعدين يروح للدكتور والدكتور يشك فيبلغ السي دي سي. ده في مجال انتشار وباء كارثه، ان اسبوعين قاعدين مش قادرين نعمل حاجه. اللي حصل حكايه لطيفه جدا مع هيئه تانية خالص ملهاش اي علاقه اساسا مباشره بالطب. الهيئه دي هي شركه جوجل، كانت نشرت بحث قبليها بفتره وجيزه ازاي ممكن يستعملوا البيانات. ايه اللي عملته جوجل؟ كانوا نشروا البحث في مجله محترمه قوي هي مجله نيتشر. ايه اللي حصل؟ ده قدروا يحددوا اماكن انتشار الفيروس على مستوى الولايات والاقاليم واحيانا بعض المدن. ازاي عملوا؟ ما لهاش اي علاقه بالطب، ودي قوه البيج داتا. جوجل بيجي لها تقريبا في اليوم الواحد 3000 مليون سيرش. ناس بتخش بتدور على معلومه، او 3 بليون سيرش في اليوم. فراحوا عملوا ايه؟ قالوا احنا عايزين نشوف في الفتره من 2003 ل 2008 قبل ما يبدا الفيروس الجديد ده ينزل، لما كان بيحصل فلو وانتشار للوباء، الناس وهي قاعده بتحكي بتعمل تشاتنج على النت بيتكلموا في ايه؟ كلام التشاتنج العادي ده. وابتدوا عملوا قاموس صغير. السي دي سي لما حب ينبه الناس لوجود وباء، ايه المفردات او الكلمات اللي استخدمها، وابتدوا باساليب ذكاء صناعي عاليه جدا يعملوا مضاهاه لما بيبقى الفلو ده موجود في منطقه معينه. ايه الكلمات اللي الناس، انا وانتوا واحنا بنحكي مع بعض على الماسنجر ولا على الفيسبوك، ايه الكلمات اللي بنستخدمها؟ فوصلوا الى عايزين، يعني ده الاوبجكتيف بتاعهم، الفريكونسي اوف certain search queries and the spread of the flu over time. ده الهدف. فلقوا فيه 45 كلمة أساسية أو مصطلح أساسي الناس العاديين بيستخدموهم أثناء انتشار الوباء، مقارنة بالقاموس اللي عملوه للسي دي سي. هو بينصح الناس استعملوا كذا وتجنبوا كذا، وابتدوا يعملوا الماتشنج. نتيجة كده وصلوا حددوا جوجل اللي بتشتغل اي تي نظم معلومات، حددوا لاكبر هيئه امريكيه في مجال الرعايه الصحيه السي دي سي الاماكن اللي فيها الفلو. وطبعا مش بسخريه لكن نقطه لطيفه ان هم عملوها تايملي، مش مستنيين اسبوعين. ده الناس النهارده الساعه 3 اتكلموا على كذا وكذا وكذا في المنطقه دي، ودي المفردات اللي بيستخدمها السي دي سي، يبقى موست بروبابلي المنطقه دي فيها فلو. طبعا ما فيهاش سخريه لكن فيها واقع. ان وصلوا للنتائج دي من غير ما يعملوا involving distributing mouth swabs or contacting physician offices. فبالتالي فكره البيج داتا فكره عظيمه جدا جدا نقدر نستخدمها. مش بنقول ان احنا دي الكومن براكتس، لكن ديفنتلي لو 57 تحمست ومعاها التمريض you are going to be pioneering in the region and in Africa in leading using big data to improve nursing knowledge. اوكي؟ مش هقدر اطيل اكتر من كده عن حضراتكم. thank you very much وبالتاكيد سعيد جدا. انا عارف الموضوع صعب شويه لكن حبيت اقدمه لحضراتكم. thank you very much. اوكي شكرا. انا اخذت 45 دقيقه استنى شيء. اوكي اوكي لان حسب الاجنده عندي 45 دقيقه.
شكرا دكتور أسامة. في حد عنده أي سؤال؟
أنا
هي عايزة
لا مش هنفتح. طب خلاص أوكي. طيب في next speaker Professor Dr. Carol Ellen Beaker, College of Nursing and Health Sciences, University Massachusetts, Boston. Okay, so we'll talk about challenges and new trends in nursing education. The time 45.
Over here. CH. Do I have to put this in here? Thank you. Good afternoon. I bring greetings from the University of Massachusetts in Boston. This is a picture of our lovely campus, which you have already seen from Dean Kalwicki. I have to say it is really an honor and a pleasure to be here today. And we've had such a wonderful experience in our visit so far. And I have to say that it's been a lifelong dream of mine to visit Egypt and to see the Nile River. I want to organize my talk today based on the nursing process. So I want to start with the problem, the challenges we have in the healthcare system, primarily the challenges we have in our healthcare system in the United States, but I think that some of them are global problems, and I think also you may learn maybe not to make the same mistakes that we've made in the past. And then I'm going to talk about nursing education. And nursing education is, in the nursing process, it's part of the diagnosis and, it's part of the plan and the treatment. And I have a little bit on outcomes, mostly on PhD nursing education. I don't know if I'm going to get to that this afternoon because I think we're kind of pressed for time. But if you have an opportunity, I'd be glad to discuss that with you. So these are some of the problems we have in our healthcare system. We have increasing demand for healthcare services due to an aging population. And that's just not in the United States, that's worldwide. And also we have an increased demand because now we have some legislation, laws that have been passed in the United States that say everybody that lives in the United States has to have health insurance. We have poor health care outcomes. We spend the most of any in developed country in health care, and yet we are number 17 in a lot of health outcomes. So we don't think that's acceptable. We've known this is a problem for some time, and we want to change it. We have health disparities, just like a previous speaker talked about, that some people in our population do not benefit from the healthcare system the way other groups in our population do. And our system is been identified as fragmented and poorly coordinated. We also have a system that's focused on illness rather than on promotion, prevention, and end of life. And so we want to change that focus a little bit and include promotion, prevention, and end of life care. And also to shift our care from expensive acute care hospitalization into home and communities. where people live. And then we have a primary care shortage. We have a shortage of nurses across the board. I think primarily we have a shortage of nurses prepared at the master's degree, those nurses that deliver primary care. And the biggest problem that gets everybody's attention in the United States, and also that both sides of the political spectrum can agree upon, is that our healthcare increases. The rate that we spend on healthcare every year increases, and we just can't sustain this increasing rate of cost. I think I have data from 2008 that says we spend over 17% of our gross national product on healthcare, and that's just not good for us. It's not good for our economy. This slide demonstrates that chronic disease is not just a problem in the United States, but chronic disease is a problem worldwide. This data is from 2005, and it shows that over 30% of the population in the world died from cancer in 2005 and all these other chronic diseases. And in fact, these are preventable. This slide gives you evidence of the shortages of nurses and physicians in Egypt, the United States, worldwide, and then also these 4 countries, Somalia, Finland, and Switzerland, and Sierra Leone, because they are the extremes, right? So you can see how the United States compares worldwide, and also how Egypt compares worldwide. And some of the poor resource countries of Somalia and Switzerland, Sierra Leone, where Finland and Switzerland are doing very well as far as providers. Now, I talked about the cost of healthcare spending. You can see on the right-hand column that how much the United States spends beyond other industrialized nations per person a year, over $8,000, and the next closest country is Switzerland. And I said, we don't have the best health outcomes. This is our President Obama, who signed the new health care bill into law in 2010. And the new health care law talks about everybody having insurance and transforming the way we deliver care. And in order to transform the way we deliver care, we have to transform nursing education. This is an example of what healthcare in the future is going to look like in the United States. We want a team-based approach to delivering primary care. You can see there's the physician, the social worker, the physician's assistant, who could just as well be a nurse practitioner, with a nurse with a master's degree. We have the pharmacists, who now have doctorates in pharmacy, who are getting more involved in prescribing and manipulating medications, especially around pain control. We have the medical assistant, who's trained maybe 1 year or 2 years, and they can do a lot of the work that the nurse and the physicians used to do. And then we have the registered nurse. So our challenge is, one of the challenges we face is, are we teaching nurses to work on teams? These are the competencies that we identify that are needed in our undergraduate curriculum. The first one is, and across all healthcare providers, is patient-centered care. We want to do team care with the patient in the center. That means we understand the patient's motivations and we understand the patient's goals and objectives, so that when we know the patient's plan, the patient goals and objectives, we can then plan our care to meet those goals and objectives. So it's not provider-driven, but patient-driven. Interdisciplinary teams I talked about, evidence-based practice. Nurses have to base their practice on research evidence. Quality improvement. Nurses have to be involved in continuous quality improvement programs. They have to have data that they analyze, that identifies problems, go to the research, look for the evidence, what kind of intervention do we want to do here, and implement it and then evaluate it. Nurses need to understand informatics. They need to understand informatics for storing data, for charting and documenting their care through data, informatics to help patients, educate patients, so for their own education, so they can access databases, so that they can do research with large data, big data, and because, you know, the information we have changes so quickly that we have to be able to access data through all these different various kinds of technologies to keep up to date. Clinical reasoning and critical thinking are not new. We've always had that in our nursing curriculum. Genetics and genomics, because that's the wave of the future. Professionalism. We need nurses that are educated at the baccalaureate level so they can perform professionally on an interdisciplinary healthcare team. We have to understand care across the lifespan, promotion, prevention, and intervention, restorative.